From San Francisco, this is Heart Rhythm Scientific Sessions 2022, and our wrap-up starts now. This is Heart Rhythm TV. We've got day 2 in the books, and we've got a new face here. Introducing Mehak Dhande from Pittsburgh, one of our fellow reporters and fellow representatives. Welcome to Heart Rhythm TV.
Thank you so much. It's great to be here.
And it's your first time at a Heart Rhythm session, or you've been here as a general fellow?
I was a fly on the wall last year, but this time definitely more involved, for sure.
And this time a lot more people.
Oh,
Energy
yeah.
Still great, day 2. We had 2 big late-breaking clinical trial sessions, one clinical innovations and the other randomized trials. Take it away. What'd you see?
Absolutely, and that was I kind of saw the Atlas trial, a couple, and that was a 1-to-1 randomization between sub-Q ICDs and transvenous ICDs, and the safety, 92% safety, no loss in performance. And the interesting thing about the trial is the patients were younger, and they had more non-CAD patients like hypertropes and those. That I thought was very interesting. Janet, what did you think?
Yeah, so I'm going to borrow your mic. So I saw, I was in the same session with you, saw the ReSync trial, which looked at left bundle pacing and BiV for CRT. And what
From China with his son presenting it.
That was what was so interesting because of all the COVID restrictions right now, right? So
From
his
China.
son
We're missing
presented.
all of the HRS members from China.
Yeah, from China. So this was great. So it was one of the first ever randomized controlled trials looking at that. And they found that in 6 months, there was improvement in EF and improvement in LV and systolic volume. So it's a nice small, pilot trial, lots of crossover, but really good data that, we can build on for
but
sure.
less crossover than his sync that I presented.
I was going to say
a
that.
little less crossover than his alternative. So this was the first conduction system pacing pilot that showed superiority.
Yeah.
Which
This
is really good. It's
great.
always been equivalent. So
Good
this one's big.
Yeah, good data. The second one I saw, which I thought was great, was the mental AF trial, right? So the mental AF trial.
Good title.
Great title. Woman PI, right? Presenter, which I thought was wonderful as
From
well.
Germany?
And she did a great job, Julia Luntz, and she talked about how they used an app with mindfulness to help decrease symptoms in AF PVI patients, and they found that it was significant. So more data to look at from there.
And certainly cost effective, because if you think about the Cabana quality of life, it's like, well, catheter ablation decreases some symptoms, quality of life, but maybe an app can do that for us as well.
There's an app for
Absolutely.
that, huh?
Yeah, that was a very nicely
The
done.
quality of life improvement app.
Yeah, and a female PI, and that was the fun part of it. Now, Dan, how was your day? And give us some updates.
It was a very fun day. I did some man in the street, walked around, connected with people, but I'll start off with talking about the late-breaking innovations. Ilan Goldenberg presented prospective data, 105 patients with long QT syndrome, long QT2, as well as medication-acquired long QT syndrome, understanding the variability with menstruation, with the menstrual cycle. I guess based upon data that outcomes become better in males post-adolescence and et cetera. So what they found was that actually higher levels of progestin and lower levels of estrogen in the menstrual cycle was actually somewhat protective or shortening the QT interval in patients with long QT2 as well as acquired long QT from medication. So very interesting and definitely a springboard forward in that data.
And just even the idea that we'll look at a QT at one static point in time and say, oh, it's long. It's not long. The whole operative word here was the dynamics of throughout the different phases, the luteal, the follicular phases. There's changes in QT.
Absolutely. And then Node 302, James Zip out of Cornell presented data for, I think, intranasal etripamil in 188 patients. And so first dose, 64% efficacy, second dose, 75%. And essentially, I think the medication is dissolved in vinegar. And so if anyone has ever sprayed vinegar up their nose, I don't think I have, on purpose at least, the side effects were associated with that. Watery eyes, 1 episode of AFib, I believe. And then Pugal Vijayaraman presented a left bundle branch area pacing in patients that were BiV failures or BiV non-responders. I think it was very interesting to include those 2 patient populations. 212 patients, 16 centers, an international observational study. And very interesting improvements in EF, improvements in heart failure hospitalizations, more profoundly in the BIV failures, but also in the non-responders. So really cool that he used those two separate patient populations. And then I guess I'll round it out with, at the table here we got Dr. Rod Tung presenting the United States Multi-Center CNA Registry, and I'll let him take it away.
Which you were a part of. But the idea that we might have a new ablation type of procedure is fun. It's exciting. And ablating the cardioneural axis and eliminating some of these GP responses and causing a functional vagal denervation may alleviate syncope in very carefully selected patients. This is all compassionate use. And we hope that this is a nice building block. It extends the observations from Brazil, from China, and then Turkey to the U.S. and with 13 centers. So it's very exciting. I mean, the one thing that really stuck out for me was when I was commenting on the epicardial brugada randomized trial, which showed that there was a reduction compared to normal care with epicardial ablation, is how many of these studies we're talking about today were not in existence 5 or 10 years ago, 15 years ago when I trained. Left bundle area pacing did not exist. Sub-Q ICDs did not exist. Cardioneural ablation did not exist. Mental apps did not exist. That's really cool to see how fluid and dynamic our field is and how rapidly progressive it is.
And it continues to move forward. I think that's what's important, right? EP continues to push the boundaries, I think.
Yes. And there was a great quote today also. I have to, Usha Tedro, the shout out, picked it up from Medscape and I put it on Twitter. And she said EP is one of the best kept secrets for women because the other thing that came out with the Stacey Howell was only 5% of EPs are women, and there's 20 states where there are no female EPs that practice.
Doing procedures.
And do procedures.
Yeah, absolutely. But I think the beauty of EP is that both male and female electrophysiologists are invested in changing that paradigm. And I think we'll get there with the right measures in place. I think we'll get there.
Absolutely.
Or at least be interventional cardiology.
Yes.
We love our colleagues.
For sure.
And let's see what Clinton.
I saw a great debate today on the question of should every person who needs a ventricular pacing get a left bundle area lead, and it was between Rod Tung and Gopi Dandamudi, and it was a hilarious assignment because Gopi Dandamudi was the one against the question, the con, and Rod was of course for it. It was highly entertaining. All the points were brought up. 1 in 3 can get. Up to 1 in 3 can get apical cardiomyopathy from pacing-induced cardiomyopathy. Are the thresholds too high with left bundle area? It seems to be less of an issue now than it was with HIS leads. Still, experienced operators sometimes only get 70% success rates, and there's a lot of back and forth. Highly entertaining, great entertainment from that room today.
Well, and we always know that we can do some things, but should we, and in whom? And those are always the questions. It's really refining patient selection is the operative word. Mm-hmm. And I think right now, either someone's all 100% conduction system pacing or they're 0. And that's part of the issue is, and whom should it be?
Yeah. So I actually wanted to bring up an interesting point, too, about PFA. I actually had a nice conversation with Dr. Hiroshi Nakagawa of the Cleveland Clinic. He presented very interesting data for PFA with regards to the importance of contact force. He brought up really interesting and important questions about durability of the lesions and the importance of knowing whether you're in contact with the tissue. And this is kind of a new paradigm because I'm not sure we were concerned about that issue. And I think it more so just highlights we need to learn more about PFA before calling it our savior. It may be, but we need to learn more.
Everyone keeps saying it's too good to be true. It's too good to be true. It's selective tissue. It's non-thermal. It's non-contact. Maybe it's not those. There's some subtleties or asterisks that we need to put next to it. So much more there too.
Yeah, we need more data.
So what are we excited about for tomorrow? Sunday.
Yeah, so tomorrow is a great day for anyone who is available. Come and join us. Tomorrow is the Diversity, Equity, Inclusion Council is holding several sessions on disparities in clinical outcomes with regards to atrial fibrillation. And also, for the first time, we have abstract session where topics related to diversity will be presented. And we have 3 judges, Dr. Hurwitz and Dr. Kusumoto and Dr. Thomas, who will be judging those. And so I'm excited. And what else is on for tomorrow?
And then we have late-breaking science.
Yes.
Yep, late-breaking science, one more session to go. Super excited about that, especially mitigating ventricular arrhythmias with gene therapy. That's always exciting. The ability to modify genes to mitigate arrhythmias is always an exciting topic.
There's one on Watchman Flex too, so we'll see how all that plays out tomorrow with those announcements.
And then the Heart Rhythm Bowl. The Heart Rhythm Bowl. That's the Super Bowl of all heart rhythm. So from San Francisco, day 2, that's definitely a wrap. We've got some new blood here, and we welcome Mehak. And can't wait for tomorrow.
Stay classy, HRS.